Good afternoon, good evening, everyone, and
Right.
thank you so much for joining us for today's Ask a Doctor series. I'm Titania Bailey, President of Arc of Knowledge, Inc. And for those of you who are unfamiliar with our organization, we're a nonprofit that provides resources towards building and strengthening relationships between our youth and seniors with the goal to create bonds that surpass differences in age and ability and ultimately create supportive, engaging environments. As part of our generational health and well-being initiative, we have the pleasure of partnering with MedStar Health and their team of specialists to provide education and resources that promote better health practices. So before I introduce our speaker, just a few housekeeping rules. Please remember to keep your devices muted throughout the presentation, and all questions can be entered into the chat. They'll be addressed at the end of our session during the Q&A portion. Our speaker for today's Ask the Doctor session is Dr. Uchechi Wosu. Dr. Wosu is an internal medicine specialist with MedStar Health and has over 20 years of experience in the medical field. She's a graduate of George Washington University Medical School, where she received a dual MD and PhD degree. She believes in educating her patients to make healthy choices to prevent chronic illness. That belief gained her recognition from the National Committee for Quality Assurance Physician Practice Connection Patient-Centered Medical Home Program. She was also awarded recognition by the American Diabetes Association Diabetes Recognition Program for her skill in providing the highest level of diabetes care. Dr. Wosu has a passion for health and wellness and is the author of Straight Talk from the Doctor, where she provides guidance on healthy living practices. Please welcome Dr. Uchechi Wosu.
Thank you so much. I actually just sent my slides over. I was having some issues sharing them, so I'm hoping that you received it so that you can go and share on your end. I sent it to Preston. If you could just confirm that you received it, that would be great. Did she receive it? Did she get it? Oh, good. Okay. All right. Well, while that's going to be shared, I am so happy to be here. As stated, I am Dr. Uchechi Wosu. I am an internal medicine physician in the DMV area. I work with MedStar, and I'm also one of the regional medical directors. And what an opportunity this is, because as a physician, we love to educate, love to teach, and oftentimes I am doing it just in my exam room behind closed doors, but I get the opportunity now to share information and educate the community, which is a huge passion of mine. So thank you to MedStar. Thank you to the Arch of Knowledge for this opportunity. I'm very grateful for that. Once the slides come up, and we can just keep on going, but I did have an agenda, and we're going to go over a couple of items. The first is discussing age-appropriate preventative screening exams. The second, going over numbers that you need to know. I know in doctor's offices, they're often throwing numbers at you and it's like, what does this mean? So I'm going to go over some of the big or major numbers you need to know. And then I'm going to discuss how to maximize your medical visit. As a physician, I'm always coaching patients on what they can say or what they should do. And so we're going to go over some tidbits on how to maximize your medical visit. And this is slide 2, the agenda. And then hopefully after we finish talking about preventative exams and discussing the numbers you need to know and how to maximize your exam, we have a good amount of time for question and answer. And I am so happy to get those questions and address the concerns you have. Next slide. So first step is going to be age-appropriate preventative exams. And before we get into that, I do want to mention that everyone is a unique individual, right? And so as we're going over these preventative exams, just know that this is for your average risk patient. So every exam, every test is always individualized. So my recommendations are for your average risk patient. Next slide. I actually borrowed this next slide from MedStar. They did a presentation on health equity. And this slide was just really powerful, really moved me because it's just amazing that in 2023, we have just still a large gap in health disparities. And so as you can see, whether it is life expectancy, whether it is the treatment of mental health, maternal health, prostate cancer, there are just huge disparities in healthcare that must be addressed. And so at least hopefully with this presentation, you would be educated on what you need to do to help reduce this gap. Oftentimes, I mean, it's not just the screening, right? There's so many different elements, so many different structural dimensions of health that go into play. But I'm hoping that this webinar will provide you or a loved one with information to help you live a healthier life and, of course, reduce this gap. Next slide. All right, so age-appropriate preventative exams. I often say that an ounce of prevention is worth a pound of cure. This is our goal as an internist. We want to make sure that we're not dealing with treating a condition. We would much rather prevent a condition. Number one, it's less expensive. It's less timely and definitely less stressful. So our goal is to prevent chronic medical illnesses from occurring rather than treating them. And so the preventative exams I'm going to discuss include cervical cancer screening, breast cancer screening, colon cancer screening, prostate cancer screening, and maybe a few other screening tests that you weren't aware of. And again, just keep in mind as we do this, go through this, this is for the average risk patient. For instance, breast cancer screening, if obviously you have a family history of a genetic mutation, this doesn't apply to you. So this is for the average risk patient. When doctors make recommendations, we often take these recommendations from the United States Preventative Service Task Force, abbreviated USPSTF. And every so often, this task force convenes to look at the data and create a recommendation that the physicians and insurance companies follow. 2016 was the last time that the USPSTF convened to create recommendations for a mammogram. And I would like to say that currently these recommendations are being updated because right now, the test of choice to screen for breast cancer is your mammogram. Most people are familiar with that. Their recommendations about when to start is in your 40s. In your 40s, you have a individualized decision that you discuss with your doctor as to should you start screening then. And as far as the frequency is concerned, they recommend that at least from 50 to 74, you have a mammogram done at least once every 2 years. So biannually. And again, this is their recommendation. As a physician, when I'm with my patient, we make that individualized decision. Like for instance, most of my patients start at 40. It's not really a discussion, but we start at 40 screening for mammograms because I'm almost certain that pretty much everyone on this webinar already knows someone who's had breast cancer, whether it's a male or female. It's just so prominent, especially in the African-American community. Unfortunately, Black women are 40% more likely to die from breast cancer. And the breast cancers in Black women tend to be more aggressive. And so since that is my primary patient population, we tend to start screening at 40. I give them this information and we continue with yearly mammograms. But I do want to give you the information as recommended by the United States Preventative Service Task Force. Statistics show that every 2 minutes, someone is diagnosed with breast cancer. So we've been on this call now for about 14 minutes. So that's 14 people who have recently been diagnosed with breast cancer. So if you are at the age of 40 and you haven't had this test done yet, I urge you just speak to your primary care doctor about the risk and the benefits to see if this is something you can get done. Again, this is for breast cancer screening, mammograms starting at 40. Next slide. The next preventative exam is cervical cancer screening. So the test of choice for this is your pap smear. And the USPSTF in 2018, as well as the American College of Obstetricians, their 2021 guidelines, both agree that screening for cervical cancer should start at the age of 21. It ends at 65, or if a hysterectomy has been done. So let me speak on hysterectomy, because there are some cases where women have a hysterectomy, but their cervix is still in place. And so they will need to continue their pap smears. The stopping doesn't apply to them. So this is for women who've had a hysterectomy with their cervix removed. So again, it starts at age 21, usually continues to age 65 for the average risk person, and is done every 3 years if cytology only is used. And you can extend it up to every 5 years if cytology along with HPV testing is used. And so you might ask, well, what is HPV? Did my doctor order this? And so, yeah, you can ask your doctor, are you doing a cytology test or are you doing adding an HPV? HPV stands for human papilloma virus. This is the virus associated with many conditions such as genital warts, throat cancer, but it's also associated with cervical cancer. So if this test is done and is negative, then the likelihood of getting cervical cancer is low. Hence, the frequency of you getting a pap smear is widened. There are different strains of HPV. The strain 16 and 18 are the ones most commonly associated with cervical cancer. And so again, this is a test that we frequently order when we're doing pap smears. Next slide. The next screening test, actually one of my favorites in terms of what I advocate for, but it's colon cancer screening. And I guess it's one of my favorites per se, is just because it's hard to convince a lot of people to get it done. I think people have a little fear, or they just don't want to have the prep solution. And so there's a lot of hesitation, but I am here today to tell you it's not that bad. Get it done. So for colon cancer screening, the test of choice, the gold standard test, is a colonoscopy. There are some other tests for colon cancer screening, such as your flexible sigmoidoscopy, your virtual colonoscopy, and there is some stool testing. But the gold standard is the colonoscopy, and I'll explain more about that in a second. Colon cancer screening starts at age 45, goes up until 75. And after that, again, you can make an individualized decision with your doctor as to how often you should continue, but definitely starts at 45 into 75. It used to be 50 and they have lowered it to 45 just because of the amount of people that were getting diagnosed. And if you get a colonoscopy and it's clear, you usually go back in 10 years, again, for the average risk patient, someone who doesn't have a history of colon cancer or a family history of colon cancer, and a clean colonoscopy every 10 years. Flex Sig is every 5 years. A CT colonography, also known as your virtual colonoscopies, are done every 5 years. And then you have your 2 stool tests, the FIT test and your Cologuard, which are done every 1 to 3 years. And these guidelines are based on the USPSTF 2021 guidelines. So my thing about colonoscopy being the gold standard, when you get a colonoscopy, you are looking at your entire colon. Not only are you looking at your entire colon, but if they were to see a polyp, which is a little pouching of mucosa or skin inside your colon, also known as that can be a precancerous lesion, they can remove it right then and there. So that's the benefit of an actual colonoscopy, where you clean your GI tract out, you get the procedure, and they can actually intervene right then and there. Flexible sigmoidoscopies do not look at the entire colon. It's only a very small portion of your colon. So you are bypassing a huge amount of colon that can actually have a polyp there and you not know it. And of course, the virtual colonoscopies Everyone asks about that, but you still have to do a prep for your virtual colonoscopies. You don't get out of that. But if they were to see something, you can't intervene. So then you have to do another prep for the actual colonoscopy. And who wants to prep twice, right? And then finally, you have your stool testing done. This looks for what we call microscopic blood, or the DNA that's associated with colon cancer. So if these tests find that, then the recommendation, of course, would be to get a colonoscopy because there's a suspicion that something's going on in your colon. And so again, the gold standard, 45 years of age, colonoscopy, if possible. And of course, there are different health conditions and cases that cause the doctor to recommend other tests. But of course, just for the purposes of screening your average risk patient, colonoscopy. Next slide, you're going to see a picture of what this looks like. So this is a picture of your large intestine. So you have your small intestines and your large intestines. When you get a colonoscopy, it is going through your large intestines to find a polyp or any other lesion. So you can see it starts with your ascending colon. Well, the colonoscopy actually goes through the rectum, up the descending colon, across the transverse colon, and down the ascending colon, even into your small intestines. When you get the flexible sigmoidoscopy, it stops right at your sigmoid colon. So you can see how much colon would be missed. The slide on the right shows a polyp. This is a picture of what can potentially be removed if you have it during your colonoscopy. Again, you can't get this done with the stool test, and you can't get this done with the virtual colonoscopy, or colonography. So colonoscopy is the gold standard. Next slide. And then we have prostate cancer screening. This is near and dear to me. My dad actually had prostate cancer about 40 years ago, but fortunately it was found early, and he is doing quite well at the young age of 91, just a couple of days ago. But the test of choice for prostate cancer screening is your PSA and or DRE. PSA stands for prostate specific antigen. This is a blood test. And the DRE is the digital rectal exam. And so there are a couple of different recommendations here. So I wanted you to see them all because there are different recommendations from different organizations. The USPSTF, they recommend starting a discussion to check your PSA from 55 to 69. The American Cancer Society believes that if you have a family history, you start at 40 to 44. If you're African-American, 45 to 49, and greater than 50 for all others to engage in shared decision-making. And the American Urological Association tends to be the most aggressive in starting prostate cancer screening at 40 to 54 for African-Americans and 55 to 69 for all others with shared decision-making. I will mention this based on that first slide. You may have missed it, but Black men have a 112% higher risk of dying from prostate cancer. That's 112% higher risk. So again, with most of my population being African-American men, we start at 40 and we continue as long as we think is necessary to continue. Again, this is one of those tests that men shy away from. If it's just a blood test that you get, that is fine. That is absolutely fine if that's what you desire and not the digital rectal exam, because it's either or, but at least get your PSA checked. Today, we have so many different advanced technologies of treating prostate cancer. And I mean, if it's treated or detected early, people do very, very well. I know at Georgetown, they have an excellent prostate cancer program in general, but for prostate cancer, the urologists are just phenomenal with innovative technology. And so again, as long as it's caught and detected, but it can't be caught or detected if you don't go into the doctor, if you don't get your PSA done. And so I'm urging you, if you're a male, over the age of 40, I'm speaking to you, or if you are a female, you have a husband, a son, a brother, someone who fits this profile, please urge them to get their prostate checked, get prostate cancer screening. Next slide. And so these are some other age-appropriate preventative exams that I want to go over that a lot of people don't know about. Many people know about breast cancer screening, cervical cancer, and so forth. But the first is aneurysm screening. And so if there's a patient, or I have a patient, a male, for instance, between the ages of 65 and 75, who have ever smoked, they need to have an abdominal sonogram done, because the abdominal sonogram checks for aneurysms. And it's a one-time test. It's not something that has to be done frequently, unless, of course, it was abnormal the first time. But they need a one-time test of an abdominal sonogram, men 65 to 75 who have ever smoked. Speaking of smoking, there is lung cancer screening. Now, this is a yearly test. This is a yearly low-dose CT scan that's done of your chest. Who would get this? This test is for adults 50 to 80 years of age with a 20-pack year smoking history, and they either currently smoke or they quit less than 15 years ago. And so 20-pack year smoking, what does that mean? It means that at least for 20 years, they've smoked 1 pack of cigarettes per day. That's a 20-pack year smoking history. Or they smoked 2 packs a day for 10 years. That's a 20-pack year smoke history. Or maybe a half a pack for about 13 years. And so you can do the math, but if you have a 20-pack year smoking history, in order to detect lung cancer early, it is recommended that you have a yearly low-dose CT scan. Of course, this is for the average risk patient. Of course, you speak to your doctor if you have any issues with dye or kidney issues. But again, barring any contraindications, this is what's recommended. I also would add that MedStar has a phenomenal smoking cessation program. And so if you are struggling with this, I urge you to ask your primary care doctor, your internist, about this program. It really does help. The next screening test is osteoporosis screening. This is done with a bone density scan, also known as a DEXA scan, and it's done every 2 years in women over the age of 65, or those who may have an increased risk of osteoporosis. For instance, if you have a strong family history of fractures, or you're on long-term chronic steroids, things that put you at a higher risk, we screen for osteoporosis, because having osteoporosis increases your risk of fractures. And so you have that. We want to be able to detect it and advise accordingly. And the last is heart disease screening. Like, what is heart disease screening? Well, this is a particular test, and it's done for a particular group of people who have that intermediate risk. It's not for the healthy 30-year-old who runs every day without any issues. It's not for the person who has 3 stents and had a bypass. And maybe for that intermediate risk group, perhaps with diabetes and high cholesterol, maybe dealing with weight struggles, we can order a coronary CT calcium score. And it just gives us an idea as to how much plaque is in your arteries. And so that will allow us to make certain decisions regarding medications, sending you for a nuclear stress test or a catheterization. But again, this is a unique test done for a specific group of people. And so those are some other screening tests that you need to speak with your doctor about if you fall into those categories. Next slide. All right, so that was a mouthful. Hopefully you all took all that in, and everyone's getting ready to make their mammogram appointments and colonoscopy appointments, hopefully, right? Okay, so numbers you need to know. Next slide. We are going to discuss 3 categories. The first is BMI, body mass index, and I have a lot to say about that. The second is blood pressure, and the third is blood sugar, or your hemoglobin A1C. Next slide. Body mass index. Oh boy, this is the one where patients come in the office and my MA, my awesome MA, Tanya, takes them to the scale and they're like, no, I don't want to get on the scale. And who knows what happens after that, but I usually get a number. So the body mass index is used calculating your weight and your height. Before I get into this, I'm going to make a statement. I've struggled with this particular test for a long time. Being an African-American female of Nigerian descent, I understand the diverse shapes and sizes of a lot of different people. And oftentimes I'm using this calculation and it comes up as obese. And I question that. I do question that. And so I dug and I did research. And I saw that the BMI was created in the 1830s by a Belgian astronomer and mathematician. And so I think, well, who was he using this system in the 1830s? So you already know the answer to that. And so I questioned, even though it wasn't at that point in time used to dictate health, by the 1970s, it was, because it's such an easy test. You just plug in your height and your weight. You can Google BMI right now, plug in your height and your weight, and you'll get your BMI. But when you think about, now in 2023, you look at the population of the United States, how diverse we are in different sizes, it doesn't truly estimate someone's health risk. And so I did add a second test that I'll talk to you about in a second that I think is a more accurate assessment of someone's health, because I've had muscular patients come in my office and using this calculation, they're obese. No, they're very healthy. They're not obese. I've had patients with a very small waist, larger hips, and they're counted as obese. I've had women with a large bust size and they're counted as obese. So again, there's a lot of flaws in this test. And so while I am going to describe it because it is a number that your doctor will calculate, I do want you to take into account some of the flaws that this test have, and we have to do better as it relates to an equitable medical situation, because this test isn't exactly completely accurate. So if your BMI is calculated as less than 18.5, you are considered underweight. If it's 18.5 to 24.9, it is considered normal. 25 to 29.9 puts you in the overweight category. And then obese, there are different levels of obesity. 30 to 34.9 is obese, severely obese. 35 to 39.9, and greater than 40, morbidly obese. And this is used to screen people for bariatric surgery. And it also has other implications with life insurance and health insurance. So that's why I'm hoping that as we move towards a more equitable world, tests like this can be replaced with my next slide, which is using your waist circumference or your waist to hip ratio. And so I know my patients like, well, Dr. Wilson, you always tell me about my BMI. I know, but it's okay. Because in my head, I understand where your health risks lie. But if we all had a measuring tape, this would probably be a more preferred test, the waist to hip ratio, because when we're looking at your risk of heart disease, what we really are looking at is the abdominal fat. Because if you have a lot of abdominal fat, it likely means you have a lot of visceral fat, which is the fat surrounding your organs. And when that happens, it leads to a cascade of inflammation, which puts you at risk for diabetes and heart disease and stroke. And so that's what we really want to check: abdominal obesity. And so the waist circumference and the waist to hip ratio would ideally do that more so than the BMI. So if you have a measuring tape, males, if your abdominal circumference is greater than 40 inches, that puts you at a greater risk. 30 greater or equal than 35 for females puts you at a higher risk. And for both, if you have a waist to hip ratio greater than 1, that means you have a higher chance of health problems. Next slide is going to show you where to put that measuring tape. So it's pretty much, the small of your waist, a little bit probably above your belly button, and then your hips right above your anterior iliac crest, like your hips, that hip bone. And then you would use your calculations with that to see. And this is good to use if someone does fall into an obese category or overweight and you question it or you question yourself, then this is something you can do and use to either support or negate that. Next slide. The next number you need to know is your blood pressure. Clearly one of, if not the most common chronic medical condition we treat in the doctor's office. And so before I go into these goals, you may ask, well, is the blood pressure goal same for someone 20 as it is for someone that's 80? The answer is yes. I mean, clearly there are some medical conditions where we will allow permissive hypertension or permissive hypotension, meaning we want your pressure to be higher or lower because of a certain medical condition. But for the most part, again, for the average risk patient, the blood pressure goals are the same. A normal blood pressure is a reading less than 120 over 80. And I will add, everyone needs a blood pressure device in your home. Like with COVID, there were three things I said everyone needed. It was a thermometer, a pulse oximeter to check your oxygen level, and a blood pressure, which also checks your heart rate. We all need this in the house. So if you don't have one, there many insurance companies cover the monitors. You can get a prescription from your doctor. If you have flex spending, you can write it off that way, but get a machine to have in your home. So normal, less than 120 over 80. Elevated blood pressure is defined as a systolic blood pressure 120 to 129 when the diastolic is less than 80. You have stage 1 hypertension if your systolic blood pressure is 130 to 139 or diastolic 80 to 89. And stage 2 hypertension if it's greater than 139 over 89. I also hear a lot of people say, well, I know when my blood pressure is high. Wow, you may have some symptoms when it's high. Oftentimes you don't, which is why it's called the silent killer. And there's also cases where you go into the doctor's office and your blood pressure is elevated. And you get home because you have a blood pressure machine at home and you check it and it's normal. So there is such a thing as white coat hypertension, meaning when you go into the doctor's office, it's high, you get home, it's normal. And that is okay. That's not something I would, typically treat. I would just want that person to continue to monitor their blood pressure closely. And you can also check your blood pressure before going into the doctor's office and bring your machine and show them, see, I checked it, and it was 116 over 65. And so there are different cases. Don't be so alarmed when you have high blood pressure. There are means of us to best manage it. Obviously, a lot has to do with what you do in your own environment as it relates to what you eat and how much physical activity you get. And there are things that we can do on our end. Blood pressure can lead to a variety of other complications, kidney disease, heart failure. I have numerous stories of just situations that I wish didn't turn out how they turned out, whether it's relatives or patients. And so I encourage you that if you do have a diagnosis of high blood pressure, you were given a diagnosis of high blood pressure, discuss your concerns, your fears with your doctor, discuss what medications they're going to put you on, discuss how to get off of those medications. That is always the goal. We don't want to always prescribe. We are your biggest cheerleaders. We want you to do well without medication. But we also understand that that's not always the case. And if you need a medication, then you should really take that medication. Next slide. And the last number you need to know, blood sugar. And so there are three categories for blood sugar. There's normal, there is prediabetes, also known as impaired fasting glucose, and then there's type 2 diabetes. You have a normal blood sugar if it's less than 100 and an A1C that's less than 5.7%. You are categorized as having prediabetes with a sugar in the range of 100 to 125 or an A1C 5.7 to 6.4. And as the slide states, if your sugar is over 125 or if your hemoglobin A1C is greater than 6.4, that is a diagnosis of type 2 diabetes. Oftentimes when I have a patient and they're in that middle category, prediabetes, that's when we take action. We're not waiting until diabetes comes. We're trying to, again, prevent it. Remember, also prevention is, worth a pound of cure. And so the goal is to prevent diabetes from occurring. And so as soon as we see those numbers going up, boom, we start action as far as what our diet is, how much physical activity I'm advising them to do so that it does not go forward into diabetes. If you do have diabetes, the American Diabetic Association or the American Diabetes Association recommends that you have your A1C checked at least twice a year. And if you're having like medication changes in management to get you to goal, then of course you need to go in more frequently, like every 3 months. And so if you're diabetic, make sure you're keeping up with your visits. I will add that diabetes, you also need to see the eye doctor and the foot doctor as recommended, but definitely make sure you're seeing your primary care doctor or your endocrinologist to best manage and this is type 2 diabetes, okay? Next slide. Okay, final category, and then we can get to Q&A. The next is how to maximize your medical visit. Next slide. So we're going to discuss what to bring to the doctor's office, what to say in a doctor's office, and what to do. So what to bring? I always love when my patients bring their medications and their supplements, especially many of my patients who are older in age or who are seeing a lot of different doctors, because oftentimes if they're not within the MedStar system, I can't see what's going on. You know, patients were like, well, can't you see? Well, no, I can't see if they're not in the system. And so I love for them to bring their medications, because you'll be surprised at how much error we find when we try to reconcile their medication in our list with what they're taking at home. It may be I said to do it twice a day and they're doing it once a day, or 3 months ago we changed the dose from 25 to 50 and they still have the 25. And so it's just really helpful to bring in the actual pill bottle over a list or over your memory when you're coming into the doctor's office. It really helps and can catch a lot of different errors. We also like you to bring your hospital discharge report. Again, if you go to a hospital system outside of your doctor practices, we can't see the hospital report. And we want to know what happened when you went to the ER, the urgent care. What did they do? What tests did they order? What did they recommend for follow-up, so that we can just pick up the ball and keep moving? And that's valuable information to make sure you're getting the continuity of care that you need. And then with Sabrine, bring support or an advocate. Sometimes I have to give some really hard diagnoses. And if you can imagine, once I'm speaking to that person and I say, you have X, Y, and Z, the brain just shuts down. And so if the doctor calls you in to discuss some news that may be unfortunate or maybe a little heavy on you, have a support system there, someone who can continue to tune in and take notes and ask questions on your behalf if you feel like you're just overwhelmed and your mind just shuts down. And so to maximize your visit, bring your medications and your supplements, bring your hospital and discharge report, and bring a support or advocate. Next slide. What to say during your medical visit? Well, you tell the truth, the whole truth, and nothing but the truth. They say it's 3 people you need to tell the truth to: but your doctor, your lawyer, and I think your pastor. So your doctor, tell us the truth. Don't tell us what you think we want to hear. When I say, are you taking your medications? You go, every well, your blood pressure is like 180/70. So I'm not so sure about that. So try to tell us the truth. We want you to be honest. We want to help you. And the only way for us to do that is if you give us the real deal about what's going on in your world, so that we can best help you. And then express your concerns, whatever it is. There's so much we don't know that's going on in your life. I mean, I've had people, for instance, blood pressure. They were going through a divorce or going through some heavy stuff. That's definitely going to affect their blood pressure. It's definitely going to affect their health. And I want to know that, because that's going to help me best manage them. I may not increase their dose. We may talk about more stress reduction or anxiety or other things that would be helpful to them. So express your concerns. Speak authentically. I can't tell you how much I love my job because the relationship that I have with my patients. I am 100% me in my office, and I want them to be 110% them, and they don't disappoint. And so speak authentically, share your concerns, share that you're afraid of a colonoscopy, share that someone had a mammogram and, this happened. And so you're afraid. We want to know what you're feeling, because again, our goal is to help you. And then share your family history. Please share your family history, because that makes a big difference. When we were talking about the preventative health exams, that's for your average risk patient. I kept on saying that because if you have a family history of a condition, that is going to allow me to order a test or write a prescription for something I may not have otherwise if I didn't know. So share your family history, or get to know and learn your family history. Next slide. So we said what to bring, what to say, finally, what to do. Take active ownership of your health. As much as, your doctor is rooting for you, we want you to root for yourself too. And so that means following up on referrals provided, discussing different health ailments that you may be having. We can't do anything about it if we don't know. And so we want you to take active ownership of your health. Get the referrals that we give you, because as an internist, we're the gatekeepers. And we can do a whole lot. But there's some things that kind of extend outside of our level of expertise and comfort. And so we may send you to a cardiologist or a pulmonologist for a reason. And we need you to follow up and get those referrals done. And if there's an issue, maybe distance or some other concern, again, authentically talk to your physician about that problem. And finally, ask your specialist to provide us with a healthcare summary if we're not getting it, or ask your primary care doctor to provide you with a summary of the visit if you need it to discuss with some of your patients. I have patients that I automatically just print it out so they can give to their wife, because I know, wife is waiting for it and she wants to know what happened at the visit. So get the summary, make sure if you see another doctor, that information gets back to us as well. And I think if you follow through about what to bring, what to say, and what to do, it's going to make your experience in that doctor's office very pleasant. Our goal is to make sure that you leave the office satisfied. You have taken off for work, you have found a babysitter, you've used some leave, so many different cases of how did you get to us today. And I acknowledge that, we acknowledge that. So we want to make sure that you are getting the care that you deserve when you're in our office. And so that's what we do at MedStar. So we want to make sure that we're taking good care of you and valuing the time that you have set aside to come and see us. Next slide. Oh, about time. Q&A, I'm a little scared, but I am ready for some questions. Are you going to read them, or are there questions that you have?
I have questions that were also sent to me, but I'm trying to read the chat to see
In
what
the chat.
and
Sorry, I had already saved them for you.
okay.
So Sabrina asked, are men screened for osteoporosis?
Great question. So men are not part of the recommendation for the United States Preventative Task Force, but depending on certain medical conditions, such as if they were on long-term steroids, they have multiple fractures, then they would be screened. So it's an individualized decision to screen men. But as far as what's recommended, it is women over the age of 65 at this time.
Okay. Thank you. And Cortina asked, is it possible to no longer need blood pressure medication?
Is it possible to? Absolutely. I've had many patients that we're able to take them off their blood pressure medication. I see Dr. Wilson, I'm sure he's had many patients that he's able to take off of their blood pressure pills with a variety of measures that people have done to either change their diet, the salt in their diet. I have sampled like a menu item that someone would choose from a fast food place. And I've Googled it and I've showed them what the sodium content in the number 4 is. And they were shocked. I mean, because the average sodium daily intake should be about 1,800, 2,000 milligrams a day. And that one meal had more than their daily requirements. And so if you were just what I call a conscious consumer of what you eat, and you know what you're eating, and is that food going to be your medicine or your poison, I think you're more likely to choose wisely, and you can come off of medications like blood pressure pills.
Okay.
You had one more question, Jacinta?
Yes. So Kelsey asked, what is the youngest age you would recommend a person to have a pap smear with cervical and prostate cancer in their family history?
The youngest age someone to, if they have a family history of cervical cancer,
Yes.
yeah, you usually don't go lower than 21, because most people don't get diagnosed below that age. And so it'll get still with the recommendations at 21 for cervical cancer screening.
Okay.
And then I will
Right,
give
with
you,
that, if someone has such a significant family history of different cancers, they may want to see an oncologist or geneticist, because something may be going on. So they would just talk to their doctor about that if there's multiple people in their family with a variety of different cancers, or cancers at a very young age.
Okay, perfect.
and I have about 6 questions that were sent to me directly. So the first one is, should you choose an internist to be your PCP?
Oh, okay. So your primary care doctor could be a general internist. It can be your geriatrician. It can be your family doctor. And so I'm using all those terms together collaboratively, whether it's your GP, general practitioner, internist, family doctor. Yes, but your internist should not be a specialist. You know, your gastroenterologist shouldn't be your internist. Oftentimes, I know people see their obstetrician who treats a variety of different issues, but you should have a general practitioner, internist, primary care doctor, family doctor, etc.
I think 2 of these questions were answered in the presentation. And then there's another one. Describe some of the most successful treatments for patients suffering from type 1 diabetes, and why do they work?
So type 1, you said?
Mhm.
So I rarely treat type 1. Once it's usually diagnosed at a younger age, and my patient population starts 18 and above. And so usually they start off with their pediatrician, and then they end up with an endocrinologist. So I wouldn't be the best person to answer that question, but an endocrinologist definitely would.
And then for the final question I have is, what do you do if you do not have access to your family history?
Well, it's nothing you can do, just make sure you're getting your proper screening test as recommended. And then you're starting the trend now. So that if anything comes up with you, you share that with the next generation, and so forth. So nothing to do, just make sure you are staying up to date with all the recommended preventative screening tests.
There's a few more questions in the chat. If we still good on time.
Yes.
Perfect. Okay. So Linda asked, when you exercise, should you go by making sure that you do 150 minutes, or should you, I guess, calculate it by the steps?
So when it comes to exercise, I'm just a fan of moving. I mean, I'm not going to tell you to buy a Fitbit and buy this. Just move as much as you can. I mean, the American Heart Association, they do have recommendations, whether it's 150 minutes a week, but exercise definitions vary depending on who you are. So you can say, I've exercised for 150 minutes, and you're just kind of leisurely walking, versus someone else maybe, running for that 150. So you just really want to mount a sufficient heart rate in that amount of time, and just move as much as you can. Yes, I love when people move over 10,000 steps a day, for sure. That lets us know that there is some activity going on. But I wouldn't get so bent on like timing yourself and like 150, okay, I'm done. for the week or what have you. So just try to move as much as you can. I try to just move when my son is at basketball practice. While he's practicing, I'm walking. I have my awesome walking buddy. I'm walking with her on Saturday. And so we just try to walk as much as we can. So just move as much as you can.
All right, thank you. And another is what is the mammo recommendation for someone with a family history?
Yeah, so it really depends on when the relative had breast cancer. So usually we like to do it 10 years, before your first degree relative had breast cancer. But again, when you're not in that category of average risk patient, then you need to have a really individualized discussion with your primary care doctor to determine when you should start your screening. But it's
Alright,
definitely earlier than others, yes.
okay. This one actually, it's a great question. I never thought of it. They ask, "Oh, why don't doctors have you take your clothes off for physicals anymore?"
I guess it depends on the doctor. In my office, we do.
Okay.
And so I guess it depends on the doctor and what they're comfortable with, what the patient's comfortable with. And so you can ask your doctor, do you need me to ungown? I like to see skin. I like to see rashes. I like to see moles. And so, yeah, it may be a preference, but it's something you can definitely ask your physician.
Okay, actually, I like that.
Mm.
The last one is what is considered a complete physical? Theirs includes blood tests, lots of questions, listening to their heart and their lungs. What more can and should we expect in a complete physical?
And that definitely is also variable depending on what office you go to, but how I would define it is one, going over your preventative tests. That's number one for me in a physical. That's our time to settle in, look at the records. Are you up to date with your immunizations? Are you up to date with your age appropriate screening exams? Are there any new information in your family history? So it's a lot of data collecting during that time, as well as a physical exam, and as well as screening of blood tests that are most common. Like I want to know your cholesterol, your sugar, things of that nature, and then give you the referrals that are needed to keep up. It may or may not include an EKG. Some offices, if you're a smoker, maybe pulmonary function test if our office does that. So you get some variability, but for the most part, it's a lot of data collection gathering, giving you the referrals for the tests that you need done in blood work.
Thank you. That was great, actually. I don't see any more. So thank you.
This was phenomenal. I love this. And I'm just so grateful for everyone who joined. I'm not sure if it's going to be recorded. Maybe they can share it with their family members. Is there going to be a link or anything to this? Do you know?
Yes, we will be, this session has been recorded and it will be
Okay.
added to both MedStar's Facebook as well as our YouTube pages for re-review, for people to send out. All the links will be available.
Excellent. And for those who are looking for a primary care doctor, please find one. MedStar has many awesome one. Dr. Wilson's one. He runs a great office in Clinton. My office is in Camp Springs. We have phenomenal physicians all over the DMV. So get yourself a doctor, a primary care doctor. And I'm hoping that this information helped you so that you can live a long, healthy, happy life.
So thank you, Dr. Wosu. Thank you for that insightful presentation and best practices for healthy lifestyle choices. We hope that all of you found this presentation helpful. And if you have not already, we'll begin to put some of these great tips into practice. Again, thank you to the MedStar team for your collaboration on this important initiative. And thank you to each of you for joining us. We hope that you will join us next month for another installment of our Ask a Doctor series, where we will be asking the neurologist. So thank you all, and please enjoy your evening.